Well, good morning. It's a great pleasure to be here, and by way of conflict of interest disclosure, I will be mentioning the American Heart Association's Get With the Guidelines registry, and I'm currently the volunteer chair of the Scientific Advisory Board. And in talking about resuscitation quality improvement, had prior funding from Laerdal and current funding from Zoll Medical for to my hospital for a resuscitation quality improvement collaborative that is multinational. In terms of enhancing hospital response to cardiac arrest with caveats for children with cardiac arrest, I'd like to build a bit on what Mimi just presented, starting first with a few caveats for children. We recognize that in-hospital cardiac arrest and out-of-hospital cardiac arrest currently have different systems of care or chains of survival based on the providers and the circumstances of arrest, and indeed children have even yet another one which has a particular focus on the left-hand side of your screen on prevention, signified by the seatbelt, so that injury and cardiac arrest prevention is of paramount importance for children in particular. We do recognize that what we know, how they're translated into guidelines and medical standards, and then taught, learned, and remembered, and translated into what we do, has we get lost in translation along those different pathways. But as we use rigorous evidence evaluation, deliberate practice, and look at ourselves and then improve, we have certain systems that have been able to dramatically improve or double survival from in-hospital cardiac arrest. We do know, and we have talked about, that more than 1,000 adults per day have cardiac arrest, and about 50 children a day have cardiac arrest or cardiac arrest with poor survival, equivalent of 2 747s for adults crashing and burning each day. For children, it's about 2 school buses worth. But of import, adults lose about 10,000 quality of life years per day from cardiac arrest, but because children are arresting predominantly very young and have a long lifespan, if appropriately recovered, that translates into about 1/3, or 3,500 quality of life years per day that could be saved. So although there's a dramatic difference, only about 10% of the number of children actually have cardiac arrest, the number of quality of life years saved could be quite important. We do recognize that children are not just little adults. The predominant cause of cardiac arrest in children, on the left-hand side of your screen, is respiratory and hypoxic in origin, particularly in neonates. And in adults, resuscitatable, good resuscitation outcomes occur when a shockable rhythm is recognized and treated appropriately. So the etiology of arrest is frequently different, and children often don't have underlying coronary artery disease or require PCI. In babies, at the extreme, although at the bottom of the pyramid, almost all babies require some immediate stimulation or support at birth, only about 3 to 6% require resuscitation in the form of bag mask ventilation, and about 1 million babies require more than that, either medication or CPR worldwide. But a simple breath of life can save more than 3 million children around the world with just a very simple intervention. It is important to recognize that most children, of the 120 million emergency visits in the United States, about 30 million are children, and 80% of those are cared for outside of children's hospital settings. So the need to be prepared to resuscitate a child is quite large, since 80% are resuscitated by those that are less familiar with children. The known interventions that make a difference for both children and adults are relatively similar. In the pre-arrest phase, protection or rapid recognition and response before arrest is particularly important. During cardiac arrest or no flow, prompt chest compression, CPR with ventilation for children, and defibrillation for a shockable rhythm are key important elements. During low flow or during cardiac arrest, CPR, pushing hard, fast, with full recoil and avoiding overventilation, plus or minus vasopressors, and treating reversible causes are both possible and simple interventions in the in-hospital setting that can be learned and trained. And in many institutions now in children's hospital settings, the institution of eCPR, ECMO, or bypass CPR is potentially possible. Selected patients. In the post-arrest phase, the targets are the same as in adults: targeted temperature management, blood pressure maintenance, oxygenation, ventilation, and recognition and treatment of seizures, and the consideration under special circumstances for PCI or thrombolysis when necessary. What it boils down to is that in the pre-arrest phase, early identification can be accomplished now with early warning scores, that low-dose, high-frequency training can be directed towards those who are at highest risk, that real-time feedback can be available, and that a team reflection or debriefing can occur that can identify performance issues. In the post-resuscitation care phase, pre-briefing followed by quantitative debriefings have been effective in almost doubling survival from in-hospital pediatric cardiac arrest. There are things that we can do and measure. Low-intensity, high-frequency training can maintain skills that are important for resuscitation. Team performance can be trained and evaluated, and the environment or system performance can be trained and evaluated. In pediatrics, we have developed a system where we can probe, using simulation, emergency departments for various standardized cases. A very simple and commonly available simulator with a trained confederate and evaluation can essentially drop an identical case into different emergency departments or hospitals, and then evaluate the readiness, the teamwork, and the time-critical interventions that are done for that standardized patient. This is an example of a spidergram report across hospitals, with our hospital in the outer rim, the gray being high pediatric volume emergency departments, and the black being low volume emergency departments. And you can see that this score could then, for instance, with our cardiac arrest case, give a performance for a hospital, and then each element of performance for that cardiac arrest case can be evaluated and compared to a standard for a similar type of hospital. The Inspire network, which is a pediatric simulation network, has done this across 30 hospitals as a demonstration project with an AHRQ grant. The performance then can be broken down with a validated scoring tool, and conceptually, in terms of what could be done, this could be translated into sort of a joint commission or national quality forum, essentially probe, that could be used across hospitals to evaluate readiness, teamwork, and time-critical performance. What I'd like to end with is sharing with you the quality measures that are used by the American Heart Association's Get With the Guidelines resuscitation for some standard performance measures that could be implemented across hospitals for adults, pediatrics, and the newly born. If we take one for example, time to epinephrine, less than 5 minutes for children and adults, could be used for asystole or pulseless electrical activity arrest. These have a rationale and have data behind them. For neonates, time to bag mask ventilation, less than 1 minute from arrest recognition, could be substituted because there's not strong data for epinephrine in the neonatal arena. Another element, whether an adult who becomes pulseless in the hospital is monitored or witnessed, or a child has their cardiac arrest in an ICU rather than ward setting, could be used as a quality metric that could be easy to track. And time to invasive airway, less than 2 minutes in the delivery room for neonates, could be a comparable type of approach. As Mimi pointed out, we have many challenges in both the data, the knowledge discovery, as well as the implementation and processing. How can we teach, learn, remember, act, and act well? And how can we assess this both in a simulated setting to have a standardized probe that could work, but also correlating that with the hospital's real data on what their performance outcomes are and their actual patient outcomes. Thank you.